I mean, do you prefer this technique of finishing handbook? Because normally handbook is not given the numbers. So I organized all the numbers for you, like which are exactly cardiology question. It took me almost a 6 months to a year. I mean, few years back to collect all these relevant things. All right. So I hope so. Yeah, it's useful actually. I mean, if you follow along with classes, the handbook is very easy. Rather than if you read handbook, my own experience was while I was studying for the MC, I realized 1 month before the exam, I didn't finish the handbook properly. Okay, so then I again had to open that one, even though it's a older book, but I did my MC like almost 9 years back, that MC part one. So that time it was not that old. Now it's quite old because there was no new version. So, but anyways, I mean, we always finish handbook. That's the thing because it's an official book, and some topics are always somewhere came in the close ones actually. So if you finish handbook, there's a thing we call, if you finish handbook properly, you manage to get somewhere like 5 to 10 questions. It is been like a myth or kind of true, but I have seen relevant topic. Say there's a pulmonary embolism topic is given. If you finish it properly, similar like topics like that will be tested in the main exam. So in that way, you can manage to cover how many questions? 5 to 10 questions. And best way to finish is along with our classes actually. So that as like me, which I had the extra burden before my exam, I had to spend another 7 days to finish that book actually. Because I feel like, I don't remember anything and where I studied what, I didn't really remember. So 1 month before the exam, I had to go through this book actually. So it was too much time consuming for me. All right. Wait, starting with the first question, like, here we go. An ECG of a 60-year man is given. All right. Sorry, we didn't bring the ECG and atrial flutter. Okay, so imagine atrial flutter, which is like a sawtooth that happens with so many palpitations. With pre-existing problem we have, I remember I mentioned hypertension is one of the predisposing for flutter. No complaint of dyspnea. Okay, that's unusual. What is the next management? So people are going for A, people are going for C. If it is a atrial flutter, what is the main concern, guys? Do you believe that the heart rate would be reaching almost nearly 300? Did I mention this thing? Yes. So heart rate is 300. That is probably the main concern at this point. So is it you want to go for warfarin first, or you want to rate the control or rate the control the rate first? So controlling the rate is more important than the concern of rhythm and this that came actually. Some people say DC cardioversion. Okay, interestingly, about DC cardioversion. Okay, some people wants to apply chat scoring. Now, see, chat scoring mostly we apply for the atrial fibrillation mode actually, not the flutter one mode. So for the atrial fibrillation, we apply it more actually. Now, is there anywhere mentioned hemodynamically instability? Hemodynamically instability, is it mentioned anywhere? Nowhere. So we will assume this patient is a stable actually. This is, please take note, if not mentioned in the question, hemodynamic instability, until proven otherwise, your patient is stable. Okay. If not mentioned unstable, means your patient is stable. Sometimes they don't mention like patient's BP, this, that. You need to assume your patient is stable. Clear? Great. Now in this question, it's loud and clear. Our answer is going to be, last day we discussed right this thing. So controlling the rate for atrial flutter. So metoprolol beta blocker to controlling the rate. Here is the reference in the Jarmota, if you remember, fibrillation and the flutter cases. Beta blocker to control the rate actually. Is it clear, everyone? So in a stable patient, controlling the rate is number one. If unstable, then we'll go with the decision. Next question. A patient came with history of dizziness, patient on thiazide and dioxin, blood pressure while standing this and on lying this, serum creatinine, urea raised. What to do next? Yes, please. Okay, guys. A lot of people are answering this thing as a B. Please note there's a line given, serum creatinine and urea is raised, and his blood pressure has some standing and lying is different. So what is this condition is called? So this condition is called somewhere postural drop or postural hypotension, and probably has been noticed actually. If postural drop has been noticed, did you remember from the MBBS there are certain drugs that can lead to postural hypotension? If you remember these things, certain drugs can lead to one of the bigger one is the antihypertensive, but among the antihypertensives, among the antihypertensive, one is predominant. Now, which one is predominant? And that one is a diuretics is high chances it is a predominant. Okay, so thiazide looks like is the winner. Thiazide looks like is the winner actually. Now, I'll upload a video and what you will see like antihypertensive lot of things actually. So mainly in the hypertension chapter, the five-star thing is this slide basically. Let me explain this slide because we haven't done the theoretical part yet. So we're taking the recall a little early, that's okay. Now you can see the diuretics in lots of situations it's given actually. Okay. Now in generally you have to remember this chart. Now if you ask me, doctor, do you have to remember? Yes. Now starting with few things. Did you remember even from your MBBS knowledge asthma and the hypertension? Asthma and the hypertension. Now do you recommend the beta blockers? Asthma cases now it is usually not recommended. So you can see the beta blocker there is a little caution given actually. Okay, so asthma one is important for our exam. Then there is a heart block. Do you consider giving beta blocker which is a rate limiter in heart block? Even beta blocker honestly is rather responsible causing heart block. So you cannot give beta blocker again. So compare contrast the asthma cases, heart block cases, and also heart failure cases. Can you also consider beta blocker in congestive heart failure? Your heart is in real trouble. Again, it's a no. So you see, initial these three conditions, ABC conditions, and like asthma, bradycardia, cardiac failure. Can I say like that? Asthma, bradycardia, cardiac failure. These ABC conditions, the beta blocker is better. We don't use it. Interesting. Can we add another thing, important one, the diabetes. In diabetes, which drug? Again, you don't want to use much. In diabetes, again, which drug you don't want to use much? Again, the answer is beta blocker. So can we say A, B, C, D? So in ABCD cases, so in antihypertensive, ABCD cases, so we don't use the beta blocker much, or even if we use very selective ones. Actually, have you heard that extreme selective ones with caution can be used actually? Okay. So these are particulars, and even in dyslipidemia cases, again with caution, we can probably use beta blocker, but again there's the issue. So diabetes, so many cases, honestly, so many cases, it's better not to use the beta blocker in the first hand actually, and some of them with the caution. Some of them you can use with the caution. The one with the star with caution, probably you can use actually. It's kind of like that. So again, another one is a ABCD, and there is a peripheral vascular disease, but you can remember this B as a Burgers disease probably. So you can remember bradycardia and Burgers together. Again, beta blocker is better not to use in the first hand actually. These are some of the important ones, but I'm going to tell you the one that is most tested, even though it's a topic related to obstetrics, pregnancy and hypertension. In pregnancy and hypertension, what is the choice? Usual cases. Most of you know about this thing actually. The answer is alpha methyl dopa. Most cases, the name is a drug of choice is a alpha methyl dopa. But you must have seen some cases where labetalol was also given a preferences. Now, the question is, in which case, labetalol is the preference, in which case alpha-methyl dopa is the preference actually. Now, if it's a general case, like say someone just got pregnant and just coming to the doctor for general health checkup, general health checkup. Now, in that case, general health checkup cases, it is alpha-methyl dopa. But if in the question it is given, the patient was brought to the hospital, okay, in the emergency department because of extreme high blood pressure, okay, or if it's a concerned thing actually, like they already knew that blood pressure is swinging high, blood pressure through the roof, they might use words like that, like blood pressure through the roof. Like in that case, it's a possibility and it's an emergency. Is hypertension extreme? High hypertension is an emergency, definitely, because it can lead to subarachnoid hemorrhage and stroke and many things. So even in pregnancy, if the blood pressure is extreme high, the patient is brought to the emergency. This situation demands labetalol. Okay. Yeah, it's even though it's given, but yeah, is even though it's mentioned, like not. Yeah. No, it's certainly not in the late term actually. Late term actually. So you can use, but not in the late trimesters, means third trimester. Clear, my dear? Okay. So most cases in the pregnancy cases, the hypertension, like first trimester or second trimester, you make the diagnosis. So first trimester, cause of hypertension are essential hypertension. I'll teach you it in obstetrics again. And second trimester hypertension, in any cases, which one is the second trimester hypertension in pregnancy? I mean, more chances, preeclampsia. First trimester hypertension, they don't know that they have hypertension. It's often the essential hypertension. Second trimester hypertension is often like a little emergency. Patient got notified. In that case, it's a preeclampsia often. So in those cases, we can give the labetalol. Is it clear to everyone? Dear doctors, is it clear to everyone? If not, I'll be again discussing this thing in the obstetric in much more details, like especially the pregnancy one. Then there's some other situation. There's another popular one other than the pregnancy, other than the heart failure, other than the asthma. These four are much more important. Renal artery stenosis, even though it's our next class topic, but it's okay, we can read it here a little bit. Renal artery stenosis cases, if anyone read the Davidson in details, is a particular drug they have mentioned not to use actually, or it is used as a somewhere confirmatory, seeing the deterioration or seeing the bad effect. The drug name is AC inhibitor. If you use AC inhibitor, the renal artery stenosis worsen, it get bad. Why? The efferent arteriole, it constricts both sides, and then the bad situation that happened actually. Okay, so renal artery stenosis cases, AC inhibitor is usually contraindicated. Clear everyone? But it's bilateral renal artery stenosis cases. Clear everyone? Bilateral renal artery stenosis cases. Now, interestingly, in kidney failure, would you like to use AC inhibitor? Interesting question. In kidney failure cases, would you like to use AC inhibitor? Honestly speaking, the early stages of kidney failure, like stage 1, stage 2, and stage 3 cases, actually we prefer using AC inhibitor. In early stages of renal failure, actually we prefer AC inhibitor. Why? Because on the effect of the proteinuria, mark that word, because of there is that proteinuria, so it's prevent that proteinuria, so it's better in the beginning. But stage 4 and stage 5, which I will tell more in the renal system, end stage renal disease, which is one of our topics. So in end stage renal disease cases, end stage renal disease cases, so that would be like AC is contraindicated. Stage 4 and stage 5. Stage 5 is known as end stage renal disease. So renal failure grade 4 and grade 5, no AC inhibitor. Okay. Then what can be the choices in that case? What can be the choices in that case? If there is a renal failure, in that case, what do you think? what can be some of the nice choices. There's some other one you can use, like there is that uh, calcium channel blocker. Calcium channel blocker is a good one. Then there's a diuretics that can be a good one. Yeah, great. All right. So this is interesting. This is interesting. We prefer, okay, interestingly, what do we prefer? Number one. I used to be hosting shows at some point of life. So thing was, I get to interview a lot of like top level professors at some point. So one day I found that at that time I started teaching MC in the earlier, then I left that shows actually. So there was a national level professor of nephrology. So I thought, okay, in between the break of the shoot, uh, let's ask him one two important things actually. There's a lot of confusion actually about that renal failure and what is the drug of choice. All right. So in that case, I get chance to ask him that, like preferred one. So preferred one, he said it depends on the pre-existing conditions, because once someone has chronic kidney disease, they also have a lot of other conditions. Am I right, guys? Like when someone has a chronic kidney disease, maybe an elderly patient. So it's not only the chronic kidney disease. Often they have a uh, diabetes together. Often they have ischemic heart disease together. So it depends on that one. Right. So in those cases, even in generally, calcium channel blocker is a good one, and also these are diuretics, but depends on taking the situation. That's how he mentioned actually. All right. So it depends on the situation. Great. But CCB is safe. Now, are you clear with this particular? And here the answer we are going with the like number 2 is a thiazide. Postural drop cases, preferred one. The causative one can be diuretics. Another important one, I have seen a question in past. SSRI can also cause postural hypotension. Am I right, guys? SSRI is also a predominant drug, can cause postural hypotension. Okay, so here the answer is thiazide. We are moving forward. So I'll give you a little idea about the antihypertensive. And this one I was supposed to tell in the theory part, mainly from the hypertension. Okay. It's interesting. This inhibitor are nominated most often recognized first-line treatment as a monotherapy. Even AC inhibitor, as you can see, is mentioned here that drug of choice even in case of renal impairment. So it means the early stages of renal impairment is a choice. Now, roughly speaking, below the age of 55, what is the drug of choice? Below the age of 55, hypertension develop below the age of 55. Previously, it was as per NICE guideline, it was 50, but now it's at 55. Below the age of the 55, the drug of choices are AC inhibitor. Above the age of the 55, this is in general, but it still depends on a lot of things. Above the age of 55, it is diuretics. Now, below the age of 55, AC inhibitor is not a choice in which group of people? This is an interesting question. Below the age of 55, AC inhibitor is not a choice in which group of people? It's mostly not a specific disease. I'm asking about a region. So it's easily mentioned that particularly black Africans, that's mentioned. Why? Its reason it's mentioned is the concentration actually. The concentration of the like, salt and these that things are a little different. Okay, so if you use the diuretics for them, the salt one will go away actually. Okay, so the salt thing it's been mentioned. It's more higher in black Africans actually. Right? Clear everyone about these things? Okay. I guess in Asian countries we also eat a lot salt, my dear. Yeah, I guess if you come to Bangladesh, you will see people also, a lot of people are taking extra salts in their plates actually. But I think it's genetic. I think it's genetic, my dear. Actually, even there are a lot of people who does not eat much salt. Yeah, I guess. Yeah. Some foods are interesting. Some foods are interesting. Yeah, so diuretic is preferred in African descent. Yes, my dear. So diuretics is even below 55 is preferred in African descent because diuretics has the property is what? Like wash away the sodium from the body. So we prefer the diuretics in African. Yeah. Great. Exhaustion. Interesting. This one is a bit related to congenital heart disease, okay, but I'll explain, don't worry. Baby delivered by normal delivery as well after birth. On the fourth day, the baby is found collapsed in a cot. Cot means, a small bed the babies are put into. And having breathlessness problem and floppy at the same time. On examination, there was no murmur. Possible cause could be fourth day, the baby collapsed in a cot. A lot of people going with TGA with PST. Now, a quick question: a TGA baby can usually died on the day one. Is it true? Normal TGA baby transposition of the great artery died in the first day because of extreme cyanosis. It is true. But if TGA with the VST, there is little chance of mixing of blood, gives them some chances for survival. Okay. So TGA with VST and AST survive a little bit more actually. So this is said fourth day. So we go with a TGA with VST. TGA with VST. Okay. Normally 1 to 2 days died, but this is fourth day because of already having another thing. Alright. Let me explain a little bit about that congenital heart disease relevant thing. Sometimes, 1 2 features can be missed. It's because of can be recalled or because of also intentionally they do it actually. But you can see the in general gross severity. By that one, we can understand actually. Okay, I hope that's clear actually. I mean, often some cases not detectable. It's a possibility. Okay, let me tell you a little bit more clear view about the congenital heart disease. We do have a note about congenital heart disease in the note, actually. Yeah, we focus on the days. Yes, you are right, my dear. Yeah, this slide may help you. Anyone seen this slide before? It's okay. I mean, I will explain now, actually. I was supposed to explain as a part of the theory class, so that's okay. Now, divided into cyanotic and acyanotic heart disease actually. Now cyanotic heart diseases are, can you name some cyanotic heart diseases? Guys, quickly, let's us all together. Cyanotic heart diseases, at least two you should be mentioning, and one is a tetralogy of Fallot and one is a TGA. So these two are the main concern things. These two are the main concern things. So collapse, breathlessness, floppy. Yeah. So looks more like situation is getting bad. There are some more tests like TOF, TGA, then truncus, total anomalous. All right. So TA, PVR. So these are like more conditions related to cyanotic heart disease, congenital cyanotic heart disease. Now, can you name some acyanotic heart disease? Very easy. AST, VST, and the PTA. AST, VST, and the PTA. These are the acyanotic heart diseases. Now, in generally, which one is most common congenital heart disease? In general, what do you think? Which one is the most common congenital heart disease? What do you think is? In generally, most common is VST. Okay, now you can see I have put a little bit information about the VST, how it can be tested in the exam. Often in newborn, hollow systolic murmur in the left border, and with the time there would be breathlessness. So you can see even congenital heart disease, breathlessness can develop a little later. Okay, so with newborn with hollow systolic, if you see a newborn, you will just pick up the VST. If you see innocent murmur, it's a very popular 5-star question. These all the lines are 5 stars. If a innocent murmur, 1 year kid was brought to the GP. Now, as a GP, you know this is a innocent murmur. Is it necessary to refer? You are a GP. The kid was brought. You find some murmur, soft systolic murmur. Is it necessary for you to refer? Or you will do reassurance? I'll give you two options. This is a very popular question. Reassurance or refer? Answer, always refer. Any murmur, in a kid under 1 year, in a kid under in an infant, any murmur is considered pathological until proven otherwise. So, infant means up to 1 year, is any sort of murmur considered pathological until proven otherwise? Good. Great. Here we go. Cyanotic, another case. Cyanotic, when there will be cyanosis. Cyanosis is what, like deoxygenated blood in the periphery. That means the it does not get enough time for oxygenation. So 6 weeks, murmur, cyanotic, special spell. Special spell is more like a like a Hilney kind of position. Now, what do you think? What it could be? This kind of situation. So this kind of situation can be tetralogy of Fallot. Often is 6 weeks. So always follow the day in the tetralogy of Fallot. They will not give you the first week or second week in case of tetralogy of Fallot. Tetralogy of Fallot, often they will give you like a 1 month or 6 weeks and something like that. So the days are very important for here. Now, next one, day one, cyanotic respiratory difficulty. There will be murmur and vital deterioration. This is a classic question actually. As like the last question, we didn't find the murmur, but classic question is supposed to give you the murmur thing, which is my concern as well. Now, in that case, in day one, the condition deteriorating will be TGA. Condition deteriorating will be TGA. But it can survive a little bit 1 day, more than 1 day, if TGA plus AST and the VST. Is it matching our question? So serious condition, TGA, but it still can survive more than 1 day if associated with TGA and the VST. We go with this concept. This question we go with this particular concept. Is it clear now, everyone? I know that murmur thing is not given here, so but still we have to follow that one. And also, I feel like this question may not be 100% complete. I mean, of course, it's not complete, but still there is a missing 1-2 puzzle in this question, I believe so, because it's a collected recall. Next, is it possible as cyanotic can develop cyanosis at some point? Definitely. There's a situation called Ising-Manger syndrome. Ising-Manger. Another one. Have you heard about a newborn with a machinery murmur? Newborn with machinery murmur. Yes, that is a PDA cases. Now, I would recommend you, I mean, of course, this slide follow from the SMA note and extra some of the thing. There is a website called Med Bullets. Have you heard about this website, guys? So check some of those congenital heart disease topics from the Med Bullets if you get some time. It's a no website, basically it's a website. Okay, but there's an option about searching in that website. So if you go there and search about the PDA, patent ductal arteriosus, they'll give you some more clinical vicinity information. Okay, you'll love that website. Other than the RSCGP, RCH, I also recommend that website. Very nice website. I used to study a lot these websites. Great. Next one is a heart picture, boot-shaped heart. Boot-shaped heart, like you can see. It's loud and clear. So cyanosis and boot-shaped heart, tetralogy of Fallot. Often they will ask you about specific management. Is PGE2 or surgery. PGE2 or surgery. You must be heard about this particular term, hole in the heart. Which condition it indicates? Like hole in the heart. Anyone? Right, guys. Yeah, let's check. Okay, someone asked a question, I think. Um, why indomethacin, I think, in PD or something like this? Any cases, guys? Indomethacin, having the patent actus arteritis is not a good news. You want it to close. You understand? You want this thing to close it, actually. So when you give the indomethacin, it helps closing the patent ductus arteriosus. Yes, by use or help of like inhibiting prostaglandin synthesis, which promotes the drug closure. Okay. Next one, important hypertension in a female, young female, unequal blood pressure. So this can be coarctation. Hypertension, female, unequal blood pressure, coarctation of the aorta. All good? Last but not the least, there can be another situation. We'll see another recall today as well. This can be one of the DD of our last question actually. Left hypoplastic heart disease, usually no murmur, less severe than TGA and the top. Now, let's come back to this one. Unfortunately, they didn't mention about the left hypoplastic heart disease. This question for me matches more with the left hypoplastic heart disease actually. Do you agree, guys? This question for me matches more with the probably left hypoplastic heart disease, which is usually less severe than the TG and the TOF. And yeah, there is no murmur actually. So it's supposed to be left hypoplastic heart disease. Since it's not an option, I have to pick up one with a TGA and the VST. Clear everyone? Sometimes we need to adjust the answers. Sometimes it is MC. We need to just little adjust the answers actually. But the best answer can be left hypoplastic heart disease here. Clear from this one? Or are you getting a better view now? Are you getting a better view now for the congenital cases, congenital situation? Now, my suggestion to you guys, this one is the summary, and what you need to do is go to the MedBullet website and search with this individual disease. Can you do that? Please take note. Enjoy Murtad, like congenital heart disease, SMA note plus med bullets. It will complete your preparation. My preparation was also complete. In first time I was studying, so when I read these things, make little notes, it was clear. But when I read the med bullet website, it was more clear for me. Wonderful. Yeah, hole in the heart is often the VST situation. Hole in the heart is the VST situation. Thank you. Next question. So those two, theory topic which was I was supposed to teach actually in the beginning actually of the class today. Actually, I take a little time for that one actually. Great. Now, a young male who suddenly fall down in a field of match without being touched, and after a few minutes he retained consciousness without any intervention. Played well. What do you think? What is it? Is it a HOCM? Can it be? Or is it a vasovagal attack? No, it's not a HOCM. It's not a HOCM. It's a common one. Understand one thing, we need to pick up the common ones. Playing for long time and suddenly become unconscious. So vasovagal attack. Now, in the same question, if I mention one line, his father died at the age of 50. Now, will it be remaining the same vasovagal attack, or now it will be HOCM? So, see, always check the questions. Always check the questions properly, because if there is a positive family history, it can be very chance of HOCM. A lot of professional players, have you heard, that they died because of this HOCM thing actually, even though they are physically very fit, but because they have an underlying issue like HOCM, they died early. Many footballers, you can tell HOCM and died. You can search in YouTube. Even there was another one, a football match was going on and suddenly collapsed and died. Yeah, all footballers were crying, but they don't have a choice. Like, match show must go on. The match has to continue actually. All right. Sometimes like bad thing happens in the field actually. If you remember, there was a, not like cardiac situation. There was a bouncer made by one fast bowler and hits the back of the helmet. One of the Australian cricketer, I think. So it hits the back of the helmet, and that person died immediately. Yeah. Yeah, Philip Hughes. Yes. Yeah. So here is the keyword from our syncope. Is the thing from our syncope. As you can see, like a vasovagal syncope, like marketplace, public place, long standing, shopping. This can lead to vasovagal syncope. Very common. Like if it's a vasovagal syncope and whatever it is, if I give you an option about management and one option about ask the witness first, which one would you prefer in that case? Ask the witness first. Okay. And here are some basic differences, which I also show you in the last day notes. If it's a cardiac syncope, the recovery process, is it faster or is it slow? If it's a cardiac syncope, recovery or post-ictal confusion would be less actually. So anyways, these are interesting. This is a small thing or nutshell. By the way, guys, Caesar would be a detailed topic in our pediatrics, but it's still some clinchers or bullet information which is often used in the exam. First time Caesar, hyponatremia, last day I mentioned about that one. Anyone who is long time in a exposure suddenly gets so much dehydrated can have hyponatremia and can have a like a short term Caesar. Recurrent seizure. That's why it is asked like you should take the drink enough water when you go to like extreme sun or extreme heat situation actually. Like recurrent seizure, serum glucose, and when stable, then only EEG. When stable, then only EEG. We'll tell more about those situations in the pediatrics, especially the epilepsy. Now, ECG of a SVT, I mean, they might not tell you in the main exam. They'll give you just the ECG. This is how the ECG looks like. Please interpret this ECG. You can see R2R distances are short, so it means it's a palpitation. These are intervals are regular. Can it be atrial fibrillation, guys, by any chance? Can it be atrial fibrillation by any chance? Answer is no. Atrial fibrillation, it would be irregular. These things would be irregular. This is regular. And now, next thing we see is a QRS. Is it a wide QRS or narrow QRS? It looks like a narrow QRS. So if it's a narrow QRS, it's SVT. Everyone agrees this is SVT. So young collapse suddenly school during the class. Okay, very young age, this is happening. So can we say below 50 this is happening? And Alkene in a minute, and after Alkene in a minute. So that means it's probably cardiac. Cardiac recoveries are faster. Take an ambulance and vital is like this, heart rate is that. ECG done and given like this. What is the initial management? Come on, guys. So initial management is the first line is a carotid sinus muscles. Carotid sinus muscles. Well done. This is also known as the vagal maneuver. So carotid sinus muscles, this is taken from the John method. So carotid sinus muscles, which is also known as the vagal stimulation. Now, if the same situation is given, is a small kid Are you going for carotid massage or something else in that case? In that case, we will go for the putting the face into the cold water actually. Okay, ice water into the face. Or immersion of the face into the water or putting the ice into the face. In kids, you cannot put their face into the water. Is rather than applying ice on the face actually. Okay, great. All right, let me check if anyone's camera is on. Let's check your cameras in case. Okay. I hope it's fine. Okay. I also nothing unusual. All right. Okay. So, Dr. Shojib Talukdar, please take care of your videos next time. Okay. And as a second step, carotid sinus massage, and in case of kids, putting ice on the face. The second step can be adenosine or vancomycin. Now, interesting one popular question in MC: if SVT is there and you tried the vagal maneuver, it didn't work. The patient has a history of asthma. Now, as a second line of management, can we go for the adenosine? Normally, we're supposed to go for adenosine, but can we go for adenosine now? Answer no. In that case, we'll go for verapamil because adenosine can cause bronchospasm. So your bronchus would be constricted in that case. So clear, everyone? I hope that's clear to everyone. Again, recommended to see the cardiac summary chart. What is the most sensitive for diagnosis aortic dissection? Our last topic, aortic dissection diagnosis. All right. Last question was, if there is asthma, you cannot use adenosine. That is the summary. So you use the verapamil. Okay. What is the most sensitive for diagnosing aortic dissection? Last we discussed few lines. We discussed about the ABC of aortic dissections. If you remember, atherosclerosis, aging, then there were a few terms right there. Right. ABC is right there. Then at the same time, and so most sensitive diagnosis is aortic dissection. It can be ruptured or unruptured, whatever it is. So here it is. So nothing mentioned about the vital. So nothing mentioned about the vital. Can it be hemodynamically unstable? Okay. Again, let's think from the previous tips. Is it a stable case or is it an unstable case? Unstable case, they will always mention it's unstable case. So this is a stable case. So if it's a stable case, do I need a ultrasound at this point? Probably not. So after the general X-ray, what we are looking forward is going for a CT scan. Very simple. Going for a CT scan. Considering all these options here, it's a CT scan. So it's the ABC, this is aging before high blood pressure, C for connective tissue and MR. If echo is an option and they're asking for the most sensitive one, it would be echo. Clear everyone? If E option echo is given, It would be an echo. Ultrasound not because even if we what we studied last year, ultrasound is normally in stable cases, initially it's more good for like screening program like aortic aneurysms, like that screening program is more nice. But if a direct they're asking like a very sensitive one, so sensitive one is not an ultrasound. Okay, or more sensitive. I mean, come on, it's logical, right? Ultrasound versus CT, which one is more sensitive? All right, great. So that'll be definitely CT scan. So we mentioned few things last year. Then initially there was X-ray, X-ray, there was widening of the mediastinum. Then there was a double barrel thing in CT scan. Yeah, yeah. I think yesterday we already discussed. Initially it's an X-ray, then comes the CT scan, then comes the echo. That's how the lineup is. Now, next one, patient with attack of MI, you started heparin. 6 hours later, abdominal swelling developed. You suspect hematoma. What to do? Interesting question. Yeah, let's go with the question. Patient with a attack of MI, you started heparin. 12 hours later, abdominal swelling developed. You suspect hematoma. What to do? Interesting question. Right, it can be a little different question than what you expected, guys. Now here is the thing. There's a thing called rectus sheet hematoma. There's a thing called rectus. No, none of you are close to this one. It's a rectus sheet hematoma is the diagnosis. Now, after an attack of MI, if there is abdominal swelling developed, that's a possibility of rectus sheet hematoma. It's a large and a stable one. Is it a stable one or unstable one? Let's check into the question one time. Is it a stable one? Is it an unstable one? They didn't mention anything about the instability. So let's assume this is a stable one. Now let's proceed. I'll show you a chart. So as you can see, there is another section. The patient is unstable. Another section where your patient is unstable, then it can be a little different. Little different. Now, in our case, hematoma large and stable. Probably. So you hold the anticoagulation, check the CBCs, and observe inpatient means in the hospital. So you stop stop this thing, the anticoagulation. So hold the anticoagulation. Let's check the question again. So rectus sheet hematoma diagnosed by abdominal CT. Fair enough. If it's a hematoma and it's large, like hold this anticoagulation thing. Now the question remains, should we go for A or should we go for the option C? In this case, this is a case of MI. Yeah, it's a good question. Yeah, showing the flowchart once again. Please take a picture of this flowchart, please. It's a little unusual topic, usually does not test it. Can you consider this thing as a pre-existing heart condition? Okay. Patient with attack of MI started heparin, and some hours later, this thing is happening. All right. Let us think for a second. Let us think for a second. This is so we are considering large, my dear. Let's assume this is a large one. Then think and proceed, guys. Like between A and the C. Let's think for 30 seconds. So it's a part of the brainstorming. Second. Yes, still C is preferred. Yeah. Yeah, because you need a antiplatelet support actually. It will cause less bleeding chances, whereas heparin has more bleeders. But still, aspirin will give you some coverage because in my cases, there is a possibility, and again there is a thrombus and this that thing. So which you don't want that thing to happen actually. Yeah. There's a thing we call risk blend. So it's A and the C, very close call actually. Without aspirin, reinfection can happen actually. So aspirin, is it mandatory? Because the patient is recently having an MI attack. So my question is antiplatelet coverage is necessary here or not? That's the question. So heparin is definitely is one of them that can cause more bleeding. So definitely needed to be stopped. But the question remains, can we go with antiplatelet support here actually? This has always been a dilemma. If you see a lot of research publication, whether to use it or not use it, so many trials, so many things are there actually. To be honest, it's not a easy thing even for the cardiologist whether to start or not actually. But certainly, the my answer is certainly aspirin, which is the antiplatelet, will give you more benefit than the risk. Okay, guys. Certainly, the aspirin will give you more benefit than the risk because it's just after the MI. So there is a huge chance that there is a thrombus thing will be formed after that. But you guys can keep research on that one. I could be wrong because this is even a big battlefield for the lot of cardiologists even actually. Okay, because this question is a little tricky for anyone even as a practical situation. So I'll go with still with the C, not changing to A. Yes. Yeah, we'll discuss more in the inquiry zone. I mean, guys, please do submit this type of questions in the inquiry zone later, actually, so that you can participate in the discussions. Okay, great. Next one, thank you. Let's move in. 50-year male with a central chest pain increasing on inspiration. Keyword is here. Chest pain increasing on inspiration. His fever is also there in ECG given. We can make it. So what is the situation? So initially oxygen is given, and after that, what you are looking forward to give, yeah, sorry, it's given, it's pericarditis. So it's a pericarditis one. Okay, so in pericarditis cases, we preferred the aspirin or the NSAIDs. Okay, keyword was uh, pain increasing on the inspiration, and the keyword was fever. So last day we were discussing this thing. It's between pericarditis and the MI. That day I didn't have the ECG visuals, but today we do have. Now you can see this one, and this one. Again here. So a lot of places it looks like ST. I mean, a lot part of the ECG looks ST elevation. So ST elevation in lot of unusual places. Diffuse ST elevation, acute pericarditis. Now, if you come and see in a MI, like you can see lead 2, then this lead 2, lead 3, APF. There's a reciprocal pattern. So this is a part of the MI situation. This is a part of the MI situation. Another MI cases, if you see, MI cases, if you see, after NEST elevation, this part is up. You know, the concavity, this thing is upwards. But if you come and see, last day I was telling about something. After the ST elevation, this particular area, can you notice the difference? Like a down sloping TP. And this is concavity little upward. So T is like a slope, like a slipper here. So ST elevation and down sloping, yeah, even here down sloping, TP. Did you notice this thing, guys? Did you notice this thing? Please comment in the comment section. Down sloping TP applicable for the pericarditis. Okay. This is important to recognize in the exams. Downsloping TP alongside ST. Pericarditis, pericardial efficient, easy things. Okay, going for the next one. A patient with a chronic heart failure, hypertension, diabetes, taking these particular drugs. Now feeling dizzy, it's quite a possible the patient is taking a couple of drugs and feeling dizzy. Should pulse is like bradycardia. ECG showing bradycardia. Sorry, you didn't read the ECG. But what do you think? The patient is taking verapamil, and you know, probably high chance. We don't know yet. But I think the rate limiters, yeah. So verapamil and the beta blocker. So any bradycardia question, always look forward. Any bradycardia question, look forward to beta blocker and calcium channel blocker. Those are the culprits. Here we go. Little magnifying. So bradycardic, beta blocker, and the calcium channel blocker. This was a nice chapter, guys. The heart block. Did you go through the SMA notes, guys? A quick asking. Did you guys go through the generally cardiology SMA notes? Cardiology part of the SMA note. If not, I mean, it's high time, guys. Please, I mean, finish the SMA note first, actually. I mean, I hope you are attending lecture. I mean, now it's very high time to finish those SMA note. Yeah. Please make sure you don't extend things too much, so that thing does not get complicated. Okay. Now, like normally why we post the overview a little early, so that you check some of the notes first, actually. Okay, here is the little tip from coming days. When we post the overview on the Fridays, when we post the overview on Fridays, you start checking the notes. That means what I'm going to highlight more in the classes, you will get to know if you check the SMA notes. Clear? Yes. No, no, but even after day one, you are supposed to finish the. It's not about the lecture two, but even after the day one, it's like so the time for assignment note is immediately after the overview to check at least, or before entering the theory class. Your life would be even more easy. You will be able to catch things even more easy. You'll be able to remember things more faster. So do this thing from the next classes, okay, guys? I mean. Uh, so of course you are studying the previous things, but say example if you take 3 4 hours, if you take 3 4 hours and just check before the class, okay, these are the things from the notes, because before the class your adrenaline will be pumped up actually. So if you just check them quickly by opening a mobile, okay, this, because it's very bullet points are given in the notes. So you will at least get the idea what important topics are coming. You'll be able to see things or do things faster. Now, next one, patient having murmur different epicardium asking which is considered as most significant. Now, this is a weird question. I didn't find much things. Age is not mentioned, which is more looks a bit incomplete. Yeah, we will send today. Okay, if anyone maybe last 2 days, I'll be sending today. You can drop me a message. Okay, if anyone not got the notes, drop me a message. Okay, the one that is considered most significant out of them, it's not a difficult one. It's easy. Okay, let me tell you. It's definitely, you know, age is not mentioned, but I assume it's elderly. Yeah, it looks in any concrete, but assume elderly. Elderly having murmur. So most dangerous one is aortic stenosis. If we assume the age is like, sometimes weird question also comes in the exam. We have seen. Yeah. So in that case, you have to consider like the most one of the dangerous one is aortic stenosis. One of the prominent cause of sudden death. One of the prominent cause of sudden death. If you take interest on the aortic stenosis, you should also take a little interest on the AHCM. Okay, so these two things can be important actually. Like differentiating point, aortic stenosis and the HOCM. HOCM often in the young athletes, whereas aortic stenosis often in elderly person. This is one of the biggest difference. HOCM also predominant in the family. Aortic stenosis, let me tell you, if you see things in an elderly person's echo, something will be mentioned as senile calcification or calcification. So narrowing and the calcification of the aortic valve, resulting in what? Resulting in left ventricular outflow obstruction, resulting in a left ventricular outflow obstruction. As the time progresses, because of outflow obstruction, there will be possibility of heart getting failure, because ventricle, left ventricle is the powerful one. It will start getting changed, and with time, it will not send enough blood, so there will be, syncope with time. And again, less blood will come to the heart, so there is a possibility of angina and other problem actually. Yeah, there's a mnemonic called SAT. Yeah, right. So main causes is a calcification, or calcification happens because of the age, rheumatic heart valve, and this that. So some surgical interventions are there. Most definitive treatment for aortic stenosis is surgeries. Most definitive management. So I recommend, like, if you get a little, nice to know, even though if you get a little bit more time, read a little bit more about the aortic stenosis surgeries actually. Read a little bit more about the aortic stenosis surgeries. No. We often see a question sometimes coming regarding the murmurs in the main STEM exams actually, it's not uncommon. So usually the questions are not difficult unless you made it complicated. Now, the thing is, you have to remember this particular slide. It's unfortunate. Uh, so this particular things you probably have to remember. It's also given in our note section, but I'll appreciate if you can uh, remember this one. I do have a mnemonic, but a bit a little bit like dirty mnemonic, I know, for that one. Okay, I'll be posting that one in the video channel. I hope that's okay, right, with your permission. Okay, check the video channel library. It's done. Okay, someone is already telling it. I don't want to mention that one. Otherwise, there will be maybe copyright issues of uploading the video later. You see, like in our live classes, there is no dermatology. Dermatology is one pre-recorded given in the video channel. Okay, if you search with the word dermatology, you will find a video, part of the medicine, but very unfortunate. Whenever I used to take Dharma, like later I cannot post it. And I got copyright strike 2 3 times because well, see Dharma with lot of terms, STDs and this that came, and the Facebook took those things as a violation of their policies and this that. Anyways, okay. I tried to make them understand this is educational, and they said like, then why in Facebook if it's educational? Okay. All right. So guys, check that mnemonic. But some of them are very important. For example, especially two of them. Just if you are lucky, I mean, remember these two well: mitral stenosis and aortic stenosis. These two are the most. So in mitral stenosis, something we remember from the low pitch, rough rumbling, mid diastolic murmur, low pitch, rough rumbling, mid diastolic murmur with an opening snap. Okay, that's how we remember low pitch, rough rumbling, mid diastolic murmur with an opening snap. Some of the things you can just keep telling and remember at the same time. And you can see this is diastolic, and yeah, check that mnemonic I uploaded. It will be easy for you to remember which one is a systolic and which one is a diastolic at least. Yeah, so aortic stenosis, mid systolic, and radius to carotid. This is crescendo, decrescendo. And of course, elderly age group for this one. Mitral stenosis, on the other hand, can be related to rheumatic heart diseases. All right, or some cases can be related to some other lung conditions as well. Okay, clear everyone so far, but you have to work hard on this part, actually remembering. So write things down if you are not having a study partner. I mean, write down and memorize. Best way is to, like, for example, if you have a study partner, okay, study partner will ask you, okay, tell me about mitral regurgitation murmur, what type of murmur? Tell me about aortic stenosis murmur, what type of murmur? So this is how another way, I mean, which we did in MBBS is a easy way actually. Next question. Old man complains about dyspnea, orthopnea, history of like this, atorvastatin, aspirin, and basal crepe, and sex are given. As Arthur, what is the appropriate next step to confirm the diagnosis? Yes, please. Yeah, someone write nice thing. We need more time to study CVS. Of course you do. So next week, even in the Tuesday, to study CVS separately. Yeah, this time little bad luck because of Eid also overlapped. So we started the cardio little later. 。 Now, is this a feature related to heart failure? Because you see, the main old man means senile heart or calcified heart. Remember, old man means probably a senile heart or a calcified heart. And presence with dyspnea is an orthopnea, another point indicating towards heart failure. All right, because dyspnea is here and history of certain things with a lot of drugs with the keyword JVP, which indicates more towards, and basal prep even more towards actually. Even X-ray given doesn't matter, we already get our information. Now, most appropriate next step to make it confirm the diagnosis. I think it's easy. It's a ANP or BNP. ANP and BNP things are released in relation with the heart failure. Do you know this information? NP and BNP, atrial natriuretic peptide. So these particular things are released in relation to heart failure. Why? Because it's like endocrine. Some of the things released inside to remove some water and the sodium. So that is why in our body we don't usually develop the fluids or edema because we have the ANP and BNP. Some cases it is not enough, and yeah, we develop heart failure actually. Okay. Same thing really released in relation with the heart failure ANP, BNP. I hope you have seen our note related to heart failure where JVP, edema, hepatosplenomegaly things are given. We discussed last day acute heart failure versus chronic heart failure. Quickly before leaving this slide, what is the main treatment for acute heart failure, guys? Before leaving this slide, I want an answer. Final answer would be is a diuretics. Is much needed diuretics. It's the mainstay. There was thing I also explained about a traffic jam. If your right heart is involved and the vena cava is involved, eventually your liver is involved and portal things are involved. So that will give rise to hepatosplenomegaly. So raised GVP, uh, hepatosplenomegaly, edema in the dependent part of the body. So that will lead to right heart failure. And there was a management thing was given about the acute heart failure and some of the other heart failures actually. I hope that's clear from the last day. 12-year-old man presents with a cyanosis affecting the lower limb but not the lower extremities. He has history of congenital heart disease which is following the best described mechanism of this presentation. It's not difficult, but they're little trying to rule out your pathophysiology, which is normally they don't test. But maybe this is one of the rare question actually. So, guys, final answer. It's a easy. It's a right to left shunt. It's a right to left shunt. Easy one. Next. 30-year-old indigenous woman means aborigine and the history of mitral stenosis. So, two important things. One is aborigine and one is a mitral stenosis. Shortness of breath for 6 weeks, low grade fever, and chest X-ray given on examination. Basal prep is present. Basal prep indicating heart failure as well. What is the probable diagnosis? This is easy. I think and the question and the day we have seen in the respiratory, it's a pulmonary hypertension. And if it's a pulmonary hypertension, how it develops, if you remember magnifying this blood, mitral stenosis. Mitral stenosis, it's a left heart valve affected. Then pressure in the left atrium developed. If left atrium pressure developed, then lungs are affected to venous pressure following arterial pressure developed. We discussed this thing last time. Here you can see pulmonary hypertension and you can see the related to left heart disease. Clear everyone? Pulmonary hypertension related to left heart disease. Now, even if you didn't understand, then even if I draw, this is the heart, the four chambers. Four chambers. This is the mitral valve, and if mitral valve affected, then this atrium is affected. Following, the lungs are affected, which is also coming into this particular left atrium. right? So eventually venous pressure following the arterial pressure. Is it clear, guys? Can we move on? Yes. Part of the pulmonary hypertension, they'll give you X-ray. Pulmonary vascular marking will be prominent. If you want to take note on the X-ray, pulmonary vascular markings will be prominent in pulmonary hypertension. Okay, with the mitral stenosis, and what kind of diastolic murmur? With diastolic murmur, left sternal border. Okay, so similar one which we already knew. So mitral stenosis related, this is how one tested. And another one we tested in past is a aortic stenosis. Another one was tested, I think it was, I think the VST and the PDA. These are the maximum thing I have seen, but anyone can come for information. So mitral stenosis, this section I took from the master keyboard book. Anyway, so few lines here. Mitral stenosis. Often this heart valve thing has relation with the rheumatic fever. Relation with rheumatic fever actually. So what we do, X-ray and ECG, and then the echo is very important, more accurate. Yeah. So transesophageal, yeah, is more important. TE is more accurate than TTE. Transesophageal echo more dependent than thoracic echo, like 2D, 3D. And yeah, this can be some of the situations. So you need diuretics because it's heart failure, and later as a management part, you can go with few of them like balloon valvoplasty, valve replacement surgeries. Read a little bit about, nice to know about valve replacement surgeries. And of course, you need an anticoagulation support like maybe a warfarin, and controlling the rate maybe with the beta blocker with the digoxin. Okay, great. Again, it's a nice to know. Next one, head ECG. Okay. Patient with a 2 hour with a chest pain and palpitation, given oxygen morphine already, blood pressure hypotensive, unstable. Ask about the initial treatment. So is it case related to chest pain for 2 hours? So chest pain with palpitation. What has been done is oxygen morphine aspirin already. So there's an instability, something has been mentioned. So main featured line looks like this in this question. Even though it doesn't matter what they have mentioned, VP hypotensive and looks unstable, so it looks unstable. Okay, now most people went for D, but please do check, do we have a better option here actually? Normally, you would always get to answer this thing, DC cardioversion, but is a line given, transfer to the cath lab. Now, in a cath lab, the DC cardioversion and many other supportive things are already there actually. Cath lab has everything actually. Okay, so the same thing in AMC, they just try to write things in a little different way. Clear everyone? Like even if you write click DC cardioversion, you're correct, but if you click E, it's a little bit more correct. All good? So they just try to fool you guys actually in the exam, or test your depth of knowledge, or update things actually. So cath lab. Okay, sorry, this particular answer was already given. But guys, let's read this question. Okay, 53, and this is a case related to chest pain radiating to the jaw, radiating pain. Upon arrival, it's a MI classic case. So it looks like a normal ECG pattern, normal troponin and everything normal. What is next? This is a very common in our practice that a patient looks like a heart attack, but ECG and troponin showing normal. Is it possible? Yes, it is possible. Now, in that case, do you need to repeat the test? Yes, we need to repeat the test. Now, the question remains, is the ECG to repeat again, or is the troponin to repeat again, as per Australian guidelines? So, answer, I mean, in our countries, probably we do the ECG thing, but the ideal is the repeating the troponin actually. Repeating the troponin actually is more I mean, important. So repeat troponin is more important. Yeah, I mean, someone said it's right. Serial ECG is in our setup. You are right. This was very confusing. Then I talked to some of the other in Australia, some of my colleagues, and they get connected with the head in the cardiology, and they mentioned that okay, troponin is better. In Australia, it doesn't matter, because everything is under the you know health packages actually. Even see, in our country, we have to consider okay, first priority is going for X-ray because CT scan is more pricey. So things are not like that in Australia. It's under the Medicare actually. So doctors also don't think about much, okay, whether giving a like a cheaper or expensive, nothing like that. Yeah, yeah. Someone says that yes, that's the thing. Getting a suit can be not more, much more expensive. Not more, much more expensive. See, a doctor earns really well in Australia. So all the thing you need is not to get sued in Australia. Actually, that's the priority I'm telling you. So that is the thing only can hamper your earning a little bit. Do you know how much an Australian doctor earn in the primary setting? I mean, HMO level 2. They call like this. This is your startup job. Okay, let me tell you per month, it's like from 8,000 to 10,000. Okay? This amount, if you don't have general registration, clear? HML level 2, no general registration, you just enter into the system. Once you finish general general registration, you are able to do locum. Do you know what is locum is? Do you know what is locum? In our country, we call cap. Those are Bangladeshi doctors, they understand. Different country people say different thing. It means that you are a doctor, you are working in a hospital, but someday in the off days, you go to another city to work for 24 hours. I don't know what is it is called in your country. In our country, we call it cap actually. Anyways, in locum is the maybe the sober term or gentle term actually. So let me tell you the locum earning. Yeah, so locum earning is like 1,200 up to 1,500 per day. Okay. So that's the thing. Your target is locum. I do have a friend. I found him. He's not under any particular company. So this guy is so smart and very lazy at the same time. Yeah. So thing is, what he does, I saw we were not under any contract. Bro, it's very fun. Like only locum, and he's just doing locum few days. Okay, and he's even earning quite a similar like others actually. Yeah, because you're under the contract, you cannot go for much locum except for the particular break days and yeah. So there's that. Yeah. Yeah, see, things are high, but doctors like it's okay. Yeah. GP is also good earning, very good earning. GP has even better life actually, to be honest. Most of a lot of my students I have seen, they started with the medical officer, like a JMO, RMO, junior medical officer, senior medical officer, later register, and then they switch to GPs actually. All right. I would say year one salary will not be that high. I mean, 8,000 to 10,000. Then it will get increased because of your locum. Yeah. Yeah. Yeah, GP there like 9 to 5, 10 to 5, kind of like this. It's more taking caring about the patients once you become GP. You know, there's a do you know that is there a home visit in Australia? I mean, even if you're a GP, your locum can be home visit as well. Yeah, yeah. Like example, like you get bonding with the people who lives nearby, but they cannot call you directly because they don't have your personal number. So they make a call to the hospital if this is your patient. Then the nurse or the person is there, maybe asking doctor, they are requesting you, I mean, in the hospital or as a home visit, because especially with the kids, this thing happened a lot because the parents get, very much anxious with the kids actually, and at the night time, you might not find the GPs. Yeah, so sometimes got called, and doctors can do home visit actually. And again, single visit can be like 300 AOTs. Yeah, just a one visit actually. Yeah, depends on what kind of patient. Yeah, definitely. Australian doctor answers really well. You don't have to worry at all. Okay. Last time we discussed about the MI thing, the monotherapy and onam therapy. Are you guys familiar with that one? Yeah, we'll go for a break after two more questions. Okay. Monotherapy, onam therapy. Okay, let's not go there. And few of the things related to MI. Please try cover these things actually. Tax will be 40%, my dear. Yeah. The more the earning, the more the taxes. A lot of my friends, up to 50. When I was earning that, that was 50% for me. Yeah. Anyways. Okay, let's go for a break, I think. Or one more, and let's go for a break. One more question. Let's do this one and go for a break. Patient on multiple drug, patient not taking drug for 5 days. JVP for centimeter raised on edema. No crackle, lungs are clear, what to give. So there is one thing not mentioned, which particular multiple drug patient not taking drug for 5 days. So as a result, JVP raised and edema crackles. So which one is important in this case? Some went for A, some went for C. Okay, now correct answer. In heart failure situation, they didn't tell us about the diuretics, unfortunately. Now, if I introduce diuretics here, what do you think? But I think diuretics is more important if the patient is a bit unstable, actually, more acute cases, like the three signs of congestive heart failure things, actually. I mean, so in that case, diuretics is more convenient. But it looks to me it's a stable case, actually. It looks to me a stable case, actually. So in that particular case, I think ACE inhibitor will be fine, actually. Okay. Now, do you know how ACE inhibitor works in heart failure, guys? ACE inhibitor works on the left ventricular remodeling, right, guys? ACE inhibitor works on the left ventricular remodeling, guys. It's not like always unstable, stable. It depends on situation. But acute heart failure, congestive heart failure cases, we prefer the diuretics. Last day we mentioned that one. Then, when stabilized, then we consider ACE inhibitor, beta blocker, or multiple drug combinations actually. Great. It looks to me a case of a bit stable, so it's inhibitor, I think. Clear everyone this question? Okay. Diuretics if acute symptoms are present. All good. When to add digoxin? When the early, like ACE inhibitor and beta blocker, is not working properly. If you check our heart failure slide, it's mentioned when to use the digoxin actually. We will see that, that in when the patient is stable and you use the ACE and beta blocker, and still the patient is not going well, then you need the digoxin thing. And later on the spironolactone thing, those can be also used as a combination. It's a very big thing. The simple way I'm telling, it's not as simple. Honestly, if anyone from the cardiology background, please ignore some of the things. For the class purpose, I have to tell in that way. But we know it is not that simple actually, right? It's a very big thing, managing especially heart failure actually. So many parameters out there, so many criteria out there. We have to look into it and introduce the drug. Okay, but for MC purpose, few of the things we cut short actually. Good. Okay, we're going for our break now. Great. We'll come back after 12 minutes. Okay, everyone, are you guys ready? Can we start? Yes. Sorry for taking 1 minute more than usual. I was enjoying a Turkish tea. Sorry about. Let's get started, guys. Have you guys like ever tried Turkish tea? I'm not sure. If you've been to Turkey or maybe Turkish cuisine, very interesting actually. It's a little different than usual. It's not because of like uh, the tea quality. It's also the making. They use double chamber of making. Yes, yeah, kebab is also of course very nice. But all the kebabs like Arabic kebabs, Lebanese, all are nice actually. No, you can in Australia actually all the cuisines are available by the way. If you're in Australia, the places like Jasmine in Sydney, if anyone are familiar, is a Lebanese cuisine and excellent actually. And some of the places, Afghan cuisines are also nice actually in Australia. Great. You'll find all cuisine, even Thai cuisines and many cuisines are really nice in Australia. Okay, moving forward. Next one. A case of suspecting acute coronary syndrome, 160 by 90, what will you give? This MI basically. So let's go for the final. Again, depends on the situation. Oxygen, if it's demanding, the situation demands actually. If they didn't mention about saturation, we will think it's fine. Again, it's a controversial question. But if in a question, if it is given, saturation is little dropping, then they need oxygen. In that case, oxygen would be given. So if 9 below 92, then they probably are breathing. They didn't mention anything about the breathing difficulties in this question. If the situation demands breathing difficulty, then definitely they need oxygen first. Otherwise, the aspirin. Aspirin is one of the drugs which prevents the mortality. Aspirin, clopid together often given. Interesting fact, let me tell you, I was studying earlier days. Giving the aspirin clopid thing or continuing the aspirin and the clopid thing, especially in a uh, stroke patient particularly. Okay, in a stroke patient particularly. Is it too good? For some cases, it can bring some complications. No, it's good for ischemic strokes. Remember one thing for ischemic stroke cases, it's good. But at the same time, when you're giving aspirin and the clopid, it's a possibility that is also a bit also increasing chance of hemorrhagic stroke at the same time. So this is a very like controversial thing. The benefit of aspirin clopid or benefit of clopid particularly, I would say. Yeah. It depends on the, is it a ST elevated MI or non-ST elevated MI? Uh, Depends on that. But if morphine is not given before, I think I would prefer going with the morphine. Okay, my dear, someone asked this question. Both have morphine and aspirin. See, aspirin will at least take few minutes to work, but when you give the morphine, it will work immediately. Subsiding the pain. Remember that term? Elephant is compressing your chin. Would you like to remove the elephant first before giving anything? It's like that. Clear, everyone? Next. A 47-year man presents with palpitation found in AF, that means atrial fibrillation with increased rate. Reverted spontaneous to sinus rhythm. This is the third episode in last 2 years. Third episode in 2 years. Okay. Echo is normal. BP is the first line of prophylaxis. Please note this case is related to atrial fibrillation. So atrial fibrillation with increased rate. In that case, what is the first liner? The first liner would be going with a beta blocker. So beta blocker here is a prololol, so bisoprolol. If metoprolol is the answer, we may choose the metoprolol or propranolol. That's also fine. This is the summary chart. Have you guys gone through this chart, guys? I mean, this is a nice summary chart. Have you guys gone through? See, review this chart again and again is very important. You will always find something important. As people said, I mean, if you have studied Davidson, anytime you are checking the Davidson again, you always find something extra. Am I right on that point, guys? That anytime revising a box, every time revising an article again, you will always find something extra. Same goes with the John Mota, same goes with the SMA notes, same goes with most of the things actually. Um, Rate control first, my dear, because with the rate, I mean, it's also related to dyspnea and the rate over the recaptures. Right. So rate you can control immediately. That's more easy than the thing. And because of the rate, see, if it's going like 300 means heart have to pump 300 times. So it means circulating, and heart might not getting enough blood, brain might not getting enough blood at the same time. So it's a possibility. Yeah. Great. So you need to control the rate, and rate control is quite a faster actually. Yeah, I mean, when rate is controlled, rhythm is also coming back at the time. All right. Also got this one. Okay. A 3-year-old previously was seen for viral infection and on examination, ejection fraction murmur heard left sternal border, and no displacement is seen. What do you think? What is the answer? I mean, there is often reason of visit. I mean, maybe child is having flu by accident. I mean, we call it incidental finding. So incidentally found there's a murmur sitting on the top. So there's a chance it can be an innocent murmur. There's a chance it can be an innocent murmur, but this question also can be flipped, and they might ask you what to do next. Would you like to refer or would you reassure? So we still like to refer. Children with murmur always refer. This 8S slide is taken from John Murtagh, soft systolic short murmur. Yeah, very weak position. Now, I'd like to ask an interesting question. Murmur with varies with position. Murmur with changes with position. What do you think, other than the innocent murmur? Answer: atrial myxoma, which is a cardiac tumor. So cardiac tumor, please remember one thing: there will be murmur, and the murmur changes with the position. Murmur changes with the position. So that is a cardiac tumor, atrial myxoma. Which of the following is the most effective agent converting paroxysmal tachycardia to normal this thing actually? So controlling the rate thing, important one would be yes, please, adenosine. Just a big agent converting. Okay, adenosine. Again, this slide is important. Okay. Again, this slide. This question was related to atrial tachycardia into normal syndrome, rate control basically. Rate controlling. A little bigger, often you get to see with longer lines in main exam. ECG will be given 65-year lady with emphysema for many years. It's a chronic lung disease with dyspnea and chest pain. ECG showing bradycardia. Some findings are given, including ST elevation in this particular leads, with ST depression in these leads, an inverted TVER. TVER is very importantly normal, and right bundle branch flow. Fifth public statement is true in this case. What do you think is? Alright, guys. Please follow up this particular finding. Sometimes you'll be given this kind of question whether the following statement is true. A bit weird. She's considered like in right statement. It's a weird question, we know, but considering so many things, if you see this ST, then follow this one, so ST segment depression as well. Probably raise ST, depression, sloping S, inverted T's. So many things. Yeah. So I think it's the basic. What I think is she's having ischemic heart disease. Even though the question is little weird. Question is a little weird, honestly speaking. Yeah. So this is a ischemic heart disease. This is ischemic heart disease. Another one, 65 years, and also for many years, patient with dyspnea. This can be another thing. So many findings. So probably the patient is having ischemic heart disease. It's like the lung, the chronic disease. The person is also having heart chronic problem. Overlapping things are not uncommon, guys. Often you will see someone having MI, but previously the person is having ischemic heart disease. It's not uncommon in practice. Okay. Patient presents in the ER with a sudden abdominal pain and pulsatile mass. So when I say abdominal pulsatile mass, your diagnosis, please. So we'll think more about the AAA, abdominal aortic aneurysm, which indicates the pulsatile mass. We tried the resuscitation by giving IV fluid cross matching. What's next is very loud and clear. Last week we mentioned this thing and say, what is it? First ultrasound. So this type of emergency cases, it's the first ultrasound. Now here is the thing, we do have a surgery class 3 emergency surgery class where I will teach you this kind of things. Unstable patient, abdominal pain, unstable patient, first ultrasound, stable patient, send for a CT scan. Very vital. This is a 5-step type of investigation. Often you will be seeing in the exam. File just injury, stable painkiller, unstable cases, intubation or CPAP. Is it clear, everyone? Okay. This one has changed. Now we are using this one. This one is a older. It was an imaging pathway, but RSCGP brought new ones actually. So previously, again with the ultrasound, we do screening process. But last day, did we mention like this? That one of the popular one was with the 4.2 What is the interval of ultrasound? I repeat, with the 4.2 size in the ultrasound one-time detection, then annually you will follow up. Annually you will follow up. Is it possible even someone is younger age group they can have aneurysm? What do you think, guys? Yes. That indicates not only abdominal, but is another aneurysm called Berry's aneurysm in the brain. Right? That's why even younger people can also have a stroke, like subarachnoid hemorrhage, because of the genetic that Berry's aneurysm actually. Okay. ECG of an adult patients with chest pain with cardiac enzyme and ECG in this that after 8 hours observation, BP goes like this. Is it normal? No, looks unstable. ECG showing SVT, but heart rate is 150. What do you think? What to do? Should you go with adenosine? Should you go with synchronized cardioversion or defibrillation, whatever it's said? So in that case, we go for synchronized cardioversion. Synchronized cardioversion. Did you? I'm sure many of you have visited developed countries. Have you seen even in the streets there are defibrillator machines out there? Have you noticed that one while traveling? Like even general streets. Okay, even in UK, even in Australia, even a lot of public places, even these things are available actually. So a lot of lives are saved because of this basic life support or advanced life support training. Um, my some of the relatives lives in Australia. As far as I know, most of them are already trained with the basic, uh, you know, this kind of, ATLS, PLS, this kind of things actually. That means if a patient who collapsed from the time of, giving the CPR, mouth to mouth breathing, and some of them also know how to give a DC shock and this that, but it's normally not allowed for general people to give, unless if someone is like a paramedics and this that actually. All right, so this is very, very important actually. And I'd highly recommend if you are in Australia, if you get some time, you can do that, BLS or ATLS course actually. Even while doing MC, not a problem. Okay, those of you who are living in Australia, if you hear me right, yes, it will take like 400 to 500 Australian dollar, but you do that one. Okay, that some of the BLS ATLS course actually, right? So why this will help you also in future? I mean, when they see your CV, I mean, maybe MC one passed at the same time. Sometimes you may have to wait for the right course in the right time. Okay, so and this will also give you CPD. So it will give you 2 years actually. Okay, normally things will give you 2 years actually. Okay, so you can do the ATLS one actually. Clear everyone? Okay, so it will help you. Those of you who are living in your country, I mean in Australia, you should definitely do it. It will give you CPT. If you're in home country, that will also give you coverage, but that may not give you the CPT. Clear everyone? Say if you're in Bangladesh, if you do the American Heart Foundation one, that will not give you the CPT. But certainly you can add that one in the CV that you have done it. So at least it's good actually. Okay. CPD, the trainings and everything. CPD, you can Google it. What is CPD? Okay, I mean, everything after MC1 will be CPD. I mean, explaining you are in training, explaining you are doing a course. Example, you are doing this course with us. After you pass MC Part 1, I mean, most doctors, they also request us to give 5 months of like CPD coverage. Okay, many, after I signed and sent that month, many of their job is confirmed as well. Of course, you need to have pre-existing 2 year and this that, but as much as when they submit all these things together, It's good actually. It's like a game. Whoever having more papers and whoever having better interview will get the job first. Is it clear? You heard me right, guys? Whoever having better experience, whoever will be showing your paper properly, like home country experience. If you're in Australia, some Australian ATLS experience, or some cases, some people do a little observership experience in Australia. Say, if you're in a Sydney, you can go to Liverpool Hospital. If you are in Melbourne, you go to Austin Health. Okay, many hospital, and nowadays you have Google. You can search where you can find observerships. Now, thing is, most cases when you finish MC1 and you go for the observership, they said, okay, we don't have any spot available. Come back later. So it's better to apply from now on. Okay, so that, and they will say, okay, you didn't pass MC1. Okay, I mean, I will be passing sooner. My exam is this time. They believe you. This kind of people actually believe everything. So my exam is this month, so I'll be clearing, so I have to join. And you give follow up to them. So in that case, they will give you the opportunity. Okay, and many of my student, they even before passing MC Part 1, they ask for the observership in Australia and they got an observership. Is it clear, everyone? So your experience, your observership in Australia, but it's not mandatory. If you have a already job in home country and you are like a medical officer, you don't need that observership. They need that observership because they are not in country, so that will give them some coverage. At least remember, 1 year equals to 1 month. Did you see my that video on the clinical gap, guys? Did you see my that particular video on the yeah, but everything is, yeah, first priority is passing MC1, but at the same time, so that you don't stretch is too much. Like normally after passing part 1, some people are taking 1 year, 1.5 year to get a job. Some people are getting the job in 2 months. Why? Because that person getting the job in 2 months is already started their preparation today to get the job, not only the pass MC1 exam. Okay, so if you're so focused, okay, some of you know that you are going to pass the exam. Okay, so I'm telling about those people, you start organizing your stuffs now. Okay, you will get the job sooner or later. From academy, like 1800 pass, I mean 1800 MC1 pass, I think round about another 400, 500 planning for MC2. And I know more than 1,000 they are doing job. All hospital IRB students I know. Okay, so some got the job early, some got the job later. Some cracked the interview early, some cracked the interview later. Some also do have difficulty in going into interview. They shake in the interviews. Some of them don't understand what they're saying because of the accents difference. Okay, so it's very important, guys, what I'm saying right now. If you're not familiar with, see, my accents more looks like kind of Asian, so it's understandable. I go slow, but see, when you go in the interview, they will be talking like crazy. Okay, some of them have accents, some of them are elder person in Australia. They have Aussie accents. It's not the same. I'm sorry. I'm sorry. You keep repeating this thing. I'm sorry. I'm sorry. They might not have a clear view on you. You understand my point? So please, start working on your not only the basic English but the understanding the Aussie accents as well. It will help you not only the cracking the interview, but someday you go to the MC part 2. These will be all the Australian patients and fake patients though, but they have the particular accent. So you see the some of the news channels related to Australia, some maybe series related to Australia will be helpful. Trust me, these tips I'm giving over the years, I give these tips, and it was helpful for many actually, right? Yeah, some said ABC News, good. Yes, but trust me one thing, a news presenter speak very clear English. Okay, rather you focus on the Australian cricket commentator, maybe some of them looks crazy. Yeah, a news presenter, like their criteria is to bring the best accents actually. Yes, great. Mixed actually, it's like different people are different. So they, as a doctor, they want you to know most of the, I mean, are you able to understand? See, a person who lives in Australia sounds different. Person living in UK sounds different. Person living in African region sounds different. Asian countries, because we're Asian, we are more familiar. it looks the same, but every of the reason it's little different. Yeah, in terms of speaking. So they want you to understand most of, like, for me it's familiar because I've been traveling on and off many years, living in abroad for 8 9 years. So for me it's different. I understood very quickly. Whoever telling in which way, I understood immediately. Sometimes we take calls also from different countries. So my saying is focus on these things, because in the main exam it's not always the OZ patient. Sometimes one to can be mixed variants. Okay, great. And here is the thing about the toxicity day pointers. Yeah. Yeah, of course, language and it's a part of the game actually, definitely. You're not understanding the language properly, it's definitely you are not fit for uh, to join. Yeah, rather than the another person who understand faster. Yeah, because there will be a lot of patience. Now, did you remember this one, long QT or toxades D pointers? So I mentioned as a B, C, D, E as a mnemonic: A for asymptomatic, B for ready, congenital drugs, and electrolyte. One thing is absent here, if you can see, hyponatremia. Like all hypo except hyponatremia. Clear, everyone? Yes. Next one. Patient on a lot of drugs. Okay. Now see, these kind of questions are common. Like when they start, like a 72-year person who presents with this problem, and that person is taking this 4 or 5 drugs. This is very common in the exam. Don't get scared. Okay, long term they're having this chronic disease, stop taking medicine 3 weeks while on a vacation. Now this is a problem happened with many people. They forget their drugs while in the vacation. Like all the day-to-day activity hampered during the vacation, except for me trying to take the classes. Anyways, now presence with edema. Uh, Up to his knees and raised JVP. So raised JVP and the edema indicating something. With clear chest sound, no crackle indicated even though. Blood pressure is high, pulses are irregular. What is the initial management in this case? All of them may look kind of right. One is a diuretic, one is a rate controller. So what do you think? So ideal, this is raised JVP edema. Isn't it like somewhere, and also check his current drug status? Isn't it because he's stopping these drugs, his heart failure symptoms probably have came back? Do you agree on that one? All right. So this is the thing. So I keep the furosemide diuretics first because indicating towards the congestive or congestion. All right. If you have a rate related problem, they will be only focusing on your heart rate. Clear, everyone? Some people may have a doubt on the three. If it's about the giving metoprolol, they will be giving the chief complaint as a rate only increased, not like this amount of symptoms and this that. I hope that's clear and that helps. Next one, I was telling why aortic stenosis related some of the surgeries are important. Like here is the one: 70-year-old male with aortic stenosis, others healthy, EF is 35, valve diameter 45. This is considered difficult question. It was not in the seminar. Now looking for a management. Now EF 35%. Can you normal cases, can you do surgeries, other surgeries? EF 35% normally can you do, but this is related to heart problem, so you have to go through something. Now, in this case, what is the right one? Okay, so we, because it's the patient is downing, patient is not all right, the patient needs valve replacement in any way, according to the references. Now, let's go here and figure out. It looks a little complicated. I want you to take a screenshot. This is not into the seminar because this is a very unusual one question. So we didn't think about keeping it as a note actually. Okay, so here is the thing. So first of all, aortic stenosis, elderly person, calcified heart valve, elderly and calcified heart valve. This is common. It can be reason for the sudden cardiac death. The patient hasn't died yet, by the way. But Okay. Now, if you can see if EF, we do have an EF in our question. So EF is less than 50%. If less than 50%, did you see what is your choices? So your choices is aortic valve replacement. We go with a aortic valve replacement. Clear, everyone? I'll hold here for a few seconds. Magnifying this one, just take a screenshot. Thirty seconds more, guys. Alright, guys. So I'll be uh, uploading a short summary on this one in our video channel. Someone, if possible, can copy and paste that thing in the Zoom chat box, please. Just now posted about a short summary regarding that. All right, that is excellent. Some of you are quick. Okay, one more mnemonic I have posted just now, guys. Its name is very clear. In the same group I have posted. I think I have shared the link of the ECG. I mean, yeah, yeah. Anyone please also post that one. Yes, my dear. You'll be clearing the screen just for a second. So sorry. Let's bring that mnemonic for you. Some may not be understanding. It's a difficult topic, so just taking 1 2 minutes more. It's for your good sake. Sharing the screen now again. Okay. So it's kind of like this. So it's a very clear the mnemonic. Mnemonic is this one. Some complicated cases if you yeah. Normally we pause for 48 hours, so since it's cardio, I will keep it a little longer time. Thank you, my dear.
And what about the group joining the groups and all which is required to access other reports and all?
Okay, so you can do a little bit um, research on this. I would recommend
Risk manager
on this particular.
so successfully you join all.
All right. All
Good.
good. I know it's a little difficult topic and it might need a little bit more research to understand actually. In generally, our purpose is served this question, but in order to understand this one, we need to go a little bit more deep down. So we just learned a mnemonic very clear about this management. Okay. ECG given interpreted as atrial fibrillation. Okay. Vice versa. A middle-aged person who is known as hypertensive, feeling dizzy and racing heart means tachycardia. It occurs after running. Okay. Travel is security psycho and he is on this particular class, which is very normal for this type of question. No mention of the other chronic heart disease, blood pressure looks fine. Maybe a little up in the systolic. What is the appropriate next step in the investigation?
So Bangalore one yesterday compute is pending.
So atrial fibrillation with a possible hypertension. So we need to rule out the cause of the atrial fibrillation. In order to rule out the causes of atrial fibrillation, one of the priority is to look into the thyrotoxicosis. If you remember last year we mentioned thyrotoxicosis. Okay, is it clear, everyone? Can you remember the four important causes of atrial fibrillation? It was in SMA note as well, I think. So starting with MI, myocardial infarction, rheumatic heart disease, ischemic heart disease, valvular heart disease, and at the same time, this thyrotoxicosis. Correct, guys? So it's always important to rule out the thyroid problem. Okay. If anyone from previous batch, I don't want you to comment in the beginning. Those are joined for the first time. Is this thing looking complicated for you? Do you want this thing to come in your exam? Those are new. Is this thing looking complicated for now? For how many it looks complicated? Okay, you can just type as complicated. Okay. Okay. Most people said it's complicated. As like relationships. I guess. All right. Okay. Okay. Coming to this one, let me try to make it easy for you. Now, first of all, it looks like this. This chart would be given, the color chart would be given, this color chart, and this is the question will be asked, and with a color chart like this. This focus means the CVD case, stroke case. Some informations are given, like a 40 year smoker, this, that. Now, from this chart, can we detect some of the things? It's a man, it's a smoker. If you see our question, it's a man, it's a smoker, it's a 40 years. It's a man, it's a smoker, it's a here. Somewhere our answer is here. Do you agree now? Man, smoker, 40. Up to this, is it clear? Please confirm. 40. Great. A little math. Yes, this chart will be given at the question. Then the blood pressure. Let's take the systolic 142 and the cholesterol 6.2 or 6. Again, let's come back. Systolic blood pressure, what was it? 142. 142, let's say 140. Can you say we are somewhere here? This is 140. And cholesterol is 6. So it is cutting in this field. So one is cross. So one is cross, one is cross. Now, what color is this? Now there is another game. I mean, we should ask the female doctors. My dear doctors, what color is this?
Blue.
I mean, what type of blue? I mean, you can tell your expertise, especially the female doctors we have.
Teal.
I mean, we male, we understand blue or sky blue as sky blue. If you ask a female about a red, they will tell you another, 10 more differentials. Yeah, you see, some people study teal blue. Never heard about this kind of term even. All right. Yes, if you have more things in your bundle by giving a different color of this one, lilac green. Okay, a lot of learning phase, guys. I mean, I want you guys to focus a little bit. We are in a learning phase of colors right now. We even don't know that this amount of color even exists. So if you want to know about colors, do ask any female. They will tell you about the colors. Okay. Coming about this one, okay, let me pretend it's kind of looking like a sky blue. This chart will be given and these numbers will be given. Okay, it's blue. Now, coming to this one, with the blue, we do have a percentage, or other thing we do have a percentage. So it is 10 to 15%. Do you have a 10 to 15%? And our answer is a B. Everyone agreed? Now, do you want this thing to coming in your exam?
They say
Now say, do you want this thing? This is like a cherry on the top in the exam. Like this is a sure short answer. Okay, this 100%. Sometimes we know when we go through the exam and we start counting. Okay, one is done, two is done, five is done. So this is one of the question that is surely done. Okay, excellent. And of course, no offense, like we guys are like color blinds, and if you ask any female about color, they will tell you 10 colors. As you see, it's a simple sky blue color. Like now, different female tell different. It's blue. I mean, if it would have been anything near to red, we'd have been in a lot of trouble. Okay. But anyways, in terms of making mistake, we think that if there will be mistake, the female can make some mistake in any way. The male will be more focused on particular color, I think. Okay. So for this question, we male probably will have more correct answer because we are more focused on the particular color actually. Anyways, fun effort, guys. Pardon me if anything. Just making jokes. Okay. Aboriginal lady has mitral stenosis and dyspnea and chest auscultation bilateral basal crepe. What chest X-ray was you were expecting? See, mitral stenosis, aborigine, basal crepe, diagnosis. Yes, pulmonary hypertension. Previously, one of the relevant, very popular in the exam called pulmonary hypertension, and all these relevant features are very important. Great. Oven on multiple drugs. Now it is normal. I didn't mention the what are the drugs I didn't because I didn't find what tricolor um, was getting in his exam. The women on multiple drug, and one of them was leucine, presented with central abdominal pain tenderness, pulse was irregular. Apart from CT scan, what is the next appropriate investigation? Yes, please. Okay, so in this case, I think because pulse is irregular, if pulse is irregular, what do you think? It's a possibility. It's a okay. So pulses irregular means atrial fibrillation. Atrial fibrillation somewhere related to thromboembolism. I repeat, atrial fibrillation related to thromboembolism. Thromboembolism related to any of the following: MI, stroke, mesenteric ischemia. Because this is related to abdominal pain, we will think mesenteric ischemia. Correct, guys? We'll think more about the mesenteric ischemia. Now, why not pancreatitis? They will tell you abdominal pain radiating towards the back, or abdominal pain presents with bruises on the umbilicus or in the flanks, because great Turner sign, Cullen sign. So it's not looking like pancreatitis perhaps. So it's more look like mesenteric ischemia. Did we know some of this surgical situation where lactate level is increased? If anyone in the surgical field, uh, we do this test, right? This lactate level actually, and it's also very commonly practiced in Australia. So serum lactate level related to mesenteric ischemia. Again, I'm telling because of atrial fibrillation, because of irregular pulse, it's more related to thromboembolic manifestation. So it's like a MI of the abdomen, which is the mesenteric ischemia, a thrombus which is blocked the mesenteric artery. Very painful situation, and we can do the serum lactate in the beginning. Then furthermore, you can do angiography, CT scans, those things furthermore. Okay, so here is a little thing. Blood is showing lactic, serum lactate level will be raised. We raised. We can also do ECG showing arrhythmias. There are other tests like CT scan and mesenteric angiography for mesenteric ischemia. One special line about mesenteric ischemia, pre-existing heart condition like atrial fibrillation, especially about the abdominal pain. Where are you going to feel the pain? Quick question. Where are you going to feel the pain? Of course, abdominal pain. More pain after eating, immediately after eating, more pain, immediately after eating, more pain in the flexures of the colon, more pain. There's two flexures. One is a hepatic flexures, one is a splenic flexure, and those parts are bit constricted. So no wonder the blood flow is little less there. So the pain you will feel more in those parts. Clear, everyone? Mesenteric ischemia cases, in those particular part, you will feel a little bit more pain than the usual. Okay, guys. Mesenteric ischemia is one of our surgical topic. I will tell you much more details about mesenteric ischemia during the surgery, but a few of the things are overlapped actually. It's okay. And here's the investigations actually. And eventually you might need surgery for mesenteric ischemia. Most cases you need a surgery. At the end it is been mentioned. Urgent surgical referral and conclusive cases needed laparotomy, open surgery. Okay. and special history, atrial fibrillation, or recent myocardial infarction. Because recent myocardial infarction also thromboembolic manifestation. Yes, this was the last question, my dear. So sorry about that. Thank you. You can clap with your study partners and say good night. If you have any further question in the drop us in the inquiry zone. I think the next class will be taking on the Sunday actually. High possibility, but if we can manage, I will inform tomorrow if I'm available by any